This is case L3 CCTA33. This is a 77-year-old man who has had progressive dyspnea on effort, a history of mild hypertension, and an abnormal stress test. We begin our review by first doing a general inspection of the study to look at quality and to also look at non-coronary structures. Here is the aortic root and the pulmonary artery as we move down. The left atrium is seen here, appears to be of normal size. There is calcified plaque in the thoracic aorta. We next define the left ventricular function. This is the horizontal long axis view, demonstrating the anterior wall, apex, and lateral wall. There does appear to be some concentric left ventricular hypertrophy. This is the vertical long axis demonstrating the anterior wall, apex, and inferior wall. Function appears to be normal to hyperdynamic. Finally, this is the short axis showing the septal, anterior, lateral, and inferior walls. There is normal global left ventricular function with no evidence of left ventricular dilation, but there is evidence suggesting left ventricular hypertrophy. This is the end diastolic frame, making a measurement of the wall thicknesses. The lateral wall measures about 15 millimeters. The anterior wall measures about 17.5. This again confirms the presence of concentric, moderately severe left ventricular hypertrophy. We now begin review of the coronary arteries. Here's the left main. There appears to be some mild plaque at the origin of the vessel. If you switch to the anterior view, you can again reconfirm this mild eccentric non-obstructive plaque in the left main. Here's the left anterior descending artery. You can see that there is some calcified plaque in the proximal segment, but if we rotate around that, you can see that this is at most mild to moderate and clearly non-obstructive. There also is some mild plaque further down. As we move into the mid-right coronary, this becomes a bit more complex because of a bit more calcified plaque. But if we switch to an MPR view here, you can get a better view of this area and see that this is again mild to at most moderate and non-obstructive. Continuing down into the distal portion of the LAD, there is some mild plaque in these segments, but otherwise the diagonals and the apical segment appears to be normal. This is the left circumflex artery, relatively large artery. As we go down, you can see that there is the vessel itself appears to be large, but in the obtuse marginal there is some calcified plaque. As you rotate around it, though, you can see that this is mild eccentric non-obstructive plaque. Reviewing around the remainder of the left circumflex, you can see that it begins to wrap around and clearly becomes the dominant vessel. As we move into these sections inferiorly, you can see that this continues along, and this is the posterior descending artery, which appears to be normal. Finally, the right coronary artery, there is some calcification near the origin of the right coronary, but as you go up and down, you can see that the coronary itself is not compromised. If you evaluate the vessel as it goes along, you can see that it's otherwise normal, it's small and non-dominant. In conclusion, this study in the 77-year-old man with an abnormal stress test and some hypertension as well as shortness of breath demonstrates non-obstructive coronary disease in the left main, left anterior descending obtuse marginal arteries with evidence of hypertrophic cardiomyopathy and aortic valve sclerosis.